Let me tell you about the day they handed you the box, and you tell me if it went something like this. You are sitting in the surgery. The consult has run about 6 minutes, and a doctor you like well enough glances at the screen and says your blood pressure is up a touch. They write something down, they hand you a script, and that is more or less the end of it. You take the script down to the chemist. You come home with a little box that has a long name on it. You cannot quite say out loud, and you put it next to the kettle. And every morning since, you have taken it with your cuppa, trusting it, and quietly wondering what it actually does inside you. Nobody told you that. Nobody told you the one side effect to keep half an eye on. And nobody told you the question that would have changed the whole conversation. So here is what I want to do for you today. If you are on perindopril, or on amlodipine, or on Irbesartan, 3 of the most common blood pressure tablets going around in this country, I am going to give you the unrushed version. The version a 6-minute appointment never has room for. Because you were told the tablet brings the number down, and that was the whole story you were handed. But the number coming down was never the thing that was going to catch a good person out. And the things that catch people out are the side effects nobody mentioned, the timing nobody explained, and the one combination at the chemist that can quietly hurt your kidneys. That is the list. 9 things. Stay with me, because the last one is the one I would want my own mum to hear. Now a word about who I am and why I am bothering. I am a doctor. I have spent the better part of my life explaining medicines to older people, across a kitchen table, in plain words, with the time to actually do it. And what I learned in all those years is that the problem is almost never the tablet. The tablet is usually doing its job. The problem is that nobody ever explained the picture. You were handed the pill and never the picture. So you take a small white tablet that changes the pressure inside your arteries, a real and powerful thing, and you do it on trust, with no idea what is normal, what is worth a phone call, and what is genuinely nothing to worry about. That gap between being handed a tablet and being told what it does is where the fear lives. It is where people stop their tablets out of worry, which is far more dangerous than the side effect ever was. So today I am closing that gap. By the end of this you will not be a doctor, but you will know the right questions to walk back in holding. And those questions change everything. So let me start with what these 3 tablets actually do, because it is simpler than it sounds, and it explains everything that comes after. Picture your blood pressure as the pressure in a garden hose. Too high for too long, and it wears out the pipes, your heart, your kidneys, the fine vessels in your eyes and your brain. These 3 tablets bring that pressure down, but they do it in 3 completely different ways. Perindopril, an ACE inhibitor, eases off a hormone system that tightens your vessels so the pipes relax. Irbesartan, an ARB, blocks that same tightening signal at the other end, a different door into the same room. And Amlodipine works straight on the muscle in the artery wall, telling it to loosen. 3 different tools, 1 job. And here is the thing the consult never has time to say, because they work in different ways, they have different quirks, different side effects, and different things to watch for. Which is exactly why a guide like this matters. I have written the unrushed version of all of this down, the plain questions to ask your own doctor about these exact tablets, in a guide called the Unrushed Visit, and I will point you to it a bit further on. For now, keep that idea in your head, 3 different tools, and let us go through the 9 things, starting gentle, and building to the one that matters most. Number 1. The cough that gets blamed on everything except the tablet. This is the classic with perindopril, and with any of the ACE inhibitors, the ones that end in pril. A dry, tickly cough, no phlegm, the kind that turns up weeks or even months after you start, and just will not clear. Now most people on perindopril never get it, so do not go looking for it. But for somewhere between about 1 in 20 and 1 in 3, more often in women, that dry cough is the tablet, not a chest infection, not the weather, not the air conditioning. It comes from a natural substance called bradykinin building up in the lungs, and Health Direct and the Australian Medicines Handbook both spell it out plainly. Here is the good news and the question. If that cough is wrecking your sleep, you do not have to put up with it, and you do not stop the tablet on your own. You ask your own doctor this: Could my cough be the perindopril, and could I try an ARB like Irbesartan instead? Because an ARB does the same job without raising bradykinin, so the cough usually settles within a few weeks. People have lived with that cough for 2 years thinking it was just them getting older. It was the tablet, and it was a 5-minute fix. Which brings me to the next one. The side effect people are most often told is their heart, when it almost never is. Number 2, puffy ankles and the heart scare that follows. This one belongs to amlodipine. By the end of the day, your ankles and your lower legs look swollen. Both sides. You press a finger in and it leaves a little dent. And the fear that comes with that, especially after 60, is the heart. But here is what is actually going on most of the time. Amlodipine relaxes the small arteries so well that a bit of fluid leaks out into the tissue of your ankles. It is local plumbing, not your heart failing, and it is dose related, so it is more likely on the 10 milligram dose than the 5. Around 1 in 10 people get it on the higher dose, and a water tablet will not fix it, because it was never extra fluid in the first place. Now here is the line that matters, the bit worth keeping. Gentle, even swelling on both ankles, no breathlessness, is usually the amlodipine. But swelling on one side only, or swelling that comes with shortness of breath, or feeling puffed lying flat in bed, that is different, and that gets you to a doctor promptly. The question for the ordinary version is simple. Could my swelling be the amlodipine, and is there an option that does it less? You do not just stop it, you ask. And keep that idea of standing up in your mind, because number 3 is about what happens when you stand. Number 3, and this is a big one for us as we get older, the head spin when you stand up, and the fall that can follow. You have felt it. You get up out of the chair, or off the bed, and for a few seconds the room goes light and swimmy. A bit of that is normal, but on blood pressure tablets in an older body it can be more than a moment. Your pressure drops when you stand, the blood pools down in your legs, nearly a pint of it, and the reflex that should snap it back up is slower than it used to be. Better Health Channel lists these tablets as a cause, and here is why I am making a fuss about a bit of dizziness. It is not the dizziness that hurts you, it is the fall. Falls are the number 1 cause of accidental injury in older Australians. 1 in 4 of us over 65 has a fall every year, and 9 in 10 of the hip fractures that land people in hospital come from a fall. So the dizzy moment is a warning worth heeding. The protection is simple, and it costs nothing. Stand up slowly. Sit on the edge of the bed for a few seconds before you rise. And if you have felt faint, tell your own doctor, because the dose or the timing might need a look. Never skip a dose to dodge the dizziness. You mention it, and you let them sort it. Now after something that serious, let us have a breather with one you have probably heard 100 warnings about, most of them wrong. Number 4, grapefruit. You have seen the warning on a sticker, you have heard it from a neighbour, and there is a real thing underneath it, but it has been badly aimed. Grapefruit can interfere with how some blood pressure tablets are broken down, pushing the levels up. But the tablets it genuinely matters for are the ones like felodipine and lurkinidipine. Amlodipine, the common one, is actually the gentle one here. The proper studies found grapefruit barely touches amlodipine. Because of the way it is absorbed, there is simply not much room for grapefruit to make a difference. So if you love a bit of grapefruit with your breakfast and you are on amlodipine, you can breathe out. The honest rule is this: if you are on felodipine or lurkinidipine, grapefruit genuinely matters, and you check it. With amlodipine, the evidence says relax, but do what you would do with any medicine you are unsure about. Have a quick word with the chemist, because they are not all the same. And speaking of the chemist, the next one is the single most important thing to ask them before you ever buy a pain tablet off the shelf. Number 5, the combination they call the triple whammy, and it is the one that quietly hurts kidneys. This is so important that MPS Medicine-wise gave it that name on purpose. Here is the setup. You are on a blood pressure tablet, perindopril or Irbesartan, and very often there is a water tablet, a diuretic, in there too. Then your back plays up, or your knee, and you grab an anti-inflammatory off the supermarket shelf. Ibuprofen, the Nurofen type, or Voltaren. Put those 3 together, the blood pressure tablet, the water tablet, and the anti-inflammatory, and you can starve your kidneys of blood flow all at once. Each one pulls a different lever, and together they can cause real kidney damage, sometimes in people who had no idea they were doing anything risky. So here is the rule that protects you, and it is a question for the chemist every time. Before you buy any anti-inflammatory off the shelf, you say, I am on blood pressure tablets. Is this safe for me? 9 times out of 10, the answer for the odd ache is plain paracetamol, your Panadol, which does not pull that kidney lever. A 30-second question at the counter. That is the whole protection, and kidneys are also the reason for the next one, the days you might actually need to pause. Number 6, the sick days. This is one almost nobody gets told, and it is gold. When you come down with a proper gastro, the vomiting and the diarrhea, or a fever that has you really crook and not keeping fluids down, your kidneys are already under strain because you are drying out. And some of these tablets, the ACE inhibitors and ARBs especially, along with water tablets and certain diabetes medicines, can add to that strain at exactly the wrong moment. So there is a thing called a sick day plan. Kidney Health Australia has it written up. It is a short list of which medicines you might pause for a day or two when you are vomiting and cannot keep water down, to protect your kidneys and then restart once you are eating and drinking again. But here is the part you must hear me on. This is a plan you set up in advance with your own doctor or chemist, so you are following instructions you already hold. It is never something you decide on your own in the moment. So the question to bring to your next ordinary appointment is this: if I get a bad gastro, should I pause any of these for a day? And how would I know? You sort that out while you are well, and it might save your kidneys when you are not. Now we are well over halfway through the list, and this is the right spot to do the thing I promised, and tell you where the unrushed version of all of this actually lives. I put together a small set of plain language guides for exactly this, for people who want to walk into the surgery prepared instead of hoping the right thing gets mentioned in 6 minutes. The one most people start with is called the Unrushed Visit, and it is simply the questions to ask, laid out for the common tablets and the common worries, so you are never again sitting in the car afterwards thinking of what you should have said. It is not medical advice, and it is not me being your doctor across the table. And it is the questions organised the way I wish every patient I ever saw had walked in holding them. The whole set, 3 guides, is up at marcus.commonguides.com, or you can scan the code on the screen right now. The complete collection is $49.99, down from $89.97, so you save $40, that is 44% off, while the founding price still holds, and there is a 7-day guarantee. Think of it this way: one rushed 6-minute consult, and the gap fee that comes with it costs more than all 3 guides put together, and it sends you home with nothing written down. This sends you home with everything written down. Right, back to the list, because the next one is the question I get asked more than almost any other, and the honest answer is not the one going round online. Number 7. The most dangerous time of day to take it? Supposedly. You will have seen the headlines. Take it at night, and you slash your risk. Take it in the morning, and you are doing it wrong. I want to be straight with you because this is your health, and you deserve the real answer. A few years ago, one big study suggested taking blood pressure tablets at night was far better. It made a splash, but that study was later seriously questioned, and then 2 much larger, more careful trials went looking for the same thing and found no difference at all. Morning or night, the protection was the same. So the honest truth today is that the best time to take your tablet is the time you will actually remember to take it every single day. Consistency beats cleverness. If night suits your routine, that is fine. If morning with your cuppa is what you will never forget, that is fine too. The one thing I will say is this: do not go switching your timing around on your own based on a headline, because for a few specific tablets, the timing does matter for other reasons. So the question, if you are curious, is simply, is morning or night better for my particular tablets? And then you leave it as they say. Which leads me to the thing that should be happening quietly in the background of all of this, and often is not. Number 8. The blood test nobody mentioned. When you are on perindopril or Irbesartan, an ACE inhibitor or an ARB, Your kidneys and a mineral in your blood called potassium are meant to be checked, not just once, but around when you start, and then regularly after. Health Direct says so plainly. Why? Because these tablets can let potassium build up a little, and too much potassium can actually upset your heart rhythm, and because they lean on your kidneys to do their job, none of that is a reason for alarm. It is a reason for a simple blood test, the kind you can have bulk billed, where they just take your bloods and check. And most people have never once been told to do it. So here is your question, and it is a gentle one. Have I had my bloods done since I started this tablet? One small extra: if you have switched to one of those potassium salt substitutes to cut down on regular salt, mention that too, because on these particular tablets, the extra potassium can be too much of a good thing. A blood test and a sentence, that is all this one asks of you. And now we come to the last thing, the most important thing on the whole list, the one I would stop you in the street to say. Number 9. Never stop suddenly, and the questions that change the next visit. If you take one thing from this whole video, take this: stopping a blood pressure tablet on your own, all at once, because of a side effect, or because you feel fine, or because you read something, can be more dangerous than any side effect we have talked about today. Your pressure can rebound, climb back up fast, and that is the moment that does real harm. Doctors are especially careful about this with certain tablets, and the principle holds for all of them. You do not just stop. You do not halve it yourself. You do not skip days. If something is bothering you, the answer is never to quietly stop. The answer is to ask, and to keep taking it until someone who knows your whole picture tells you otherwise. Because here is the truth underneath this entire list. Almost nothing on it is a reason to come off your tablet. Every single thing on it is a reason to ask a better question, and those questions are the real gift of today. Could this cough be the perindopril? Could this swelling be the amlodipine? Have I had my bloods done? Should I have a sick day plan? Is my timing right for me? You walk into a 6-minute appointment holding those, and a rushed visit becomes a real conversation about your own body. So before I let you go, let me give you one small thing to do, right now while you are thinking of it. Pause this if you need to. Go and get the box your tablets actually come from, the one by the kettle or in the cupboard, and read the name on it, just the name. Is it perindopril, or amlodipine, or Irbesartan, or a brand like Coversyl, or Norvasc, or Avapro? And then, on whatever is nearest, the back of an envelope, write down the one question from today that fits you. That is it. You now have a name and a question, which is more than most people walk into the surgery with. And to be clear, that is the only thing I am asking you to do. I am not asking you to change a single tablet. This was never about doing something different on your own. It was about being able to ask. Because here is what makes me cross, in my quiet way after all these years. None of this is hidden. Nobody is keeping it from you. The cough, the swelling, the bloods, the sick days. It is all written down, all known, all ordinary medicine. The reason you were never told is far more boring and far sadder than a conspiracy. It is time. The appointment is 6 minutes long. Your doctor is good and kind and watching the clock with a full waiting room behind you. The chemist is flat out. Nobody ever built in the 10 minutes it takes to explain a tablet properly, so the explaining just quietly fell off the edge of the system. You were handed the pill, and never the picture. That is the whole story. And if this video has done one thing, I hope it has handed you a little of that picture back and made you feel like the person in charge of your own health again, which you always were. If that is worth something to you, the kindest thing you can do is send this to the one person you know who takes a tablet every morning and has never once been told what it does. Your partner, your neighbour, the bloke at the footy. Pass it on. And if you do want those questions in your hand, written down the way I wish every patient walked in holding them, that is exactly what the Unrushed Visit is for. The whole setup at marcus.commonguides.com, or scan the code on the screen. But hear me on this, because it matters more than the guide ever could. The guide is the smaller gift today. The bigger one is already sitting in your own kitchen, in the box by the kettle, and in the one question you are now going to ask. You have that part already, and nobody can take it back. Before we finish, the part 1 will never skip, because it matters more than anything else I have said. Everything today is education, not a diagnosis, and I have not examined you. So do not change, reduce or stop any tablet on your own. Talk to your own doctor or your chemist first, always. And know the line that is not a wait and see line. If you ever have chest pain, or sudden weakness, or drooping on one side of your face or body, or trouble speaking, or a severe allergic reaction with swelling of the lips or throat, or you faint, that is not a moment for the internet. That is a call 000 moment, straight away. The whole point of today was never fear, it was the opposite. It was so the next time you sit in that surgery, with 6 minutes on the clock, you are not just nodding along and hoping. You know what your tablet does, you know the one thing to watch, and you have your question ready. You were handed the pill, now you have a bit of the picture. Look after yourself. And I will see you in the next one, where we are going to do exactly this for the cholesterol tablets, the statins, and the one side effect that gets blamed on old age more than any other.